Hello, good afternoon, everybody. Here we are again in our evening press conference number 98. This is day 5 of the new normal. And we must remember that the new normal does not mean that we are refraining from self-distancing. The new normal does not mean that all activities are open. It means that using our COVID-19 risk stoplight, we will focus on healthy distancing activities and related activities that will take place region-wise throughout the different federal entities. In a few seconds, we will provide you with the map, the risk map, available as of next week. Certain actions will be adopted, whereas others will we will not engage in certain activities. This is the map. This is a visual representation of the lack of a curve reduction. Basically, the figures are stagnated. The amount of cases after the 14th and 15th days just report similar cases. This is why the percentages of the total amount of the pandemic, which is 63%, as well as their percentages throughout the different regions that remain the same throughout the Americas, which is the region we belong to, the 55% remains. So for growth purposes, there is stability, but we must also, but in terms of a reduction of the pandemic throughout the world, no. The different regions are still active. These are the figures. Mexico, 324,897 individuals are part of the study protocol. They've presented signs and symptoms compatible with COVID-19. Therefore, they've been classified as suspected cases. They're part of the study protocol. 166,049 tested negative for COVID-19. Today, there are 110,026 cases, although less than 1/5 of these cases make up the active epidemic in Mexico. 19,015 persons presented symptoms in the past 2 weeks. You should notice that less than 1/5 part, 18% of all cases, still remain, hence reducing certain percentage points throughout the week. This is why we claim a reduction in the number of ill patients throughout the last 2 weeks. And we must take a look at this from the 48,822 suspected cases that may still nourish the active epidemic. We still find positive percentages if positive cases are confirmed. 13,170 people unfortunately died due to disease-related complications. In this slide, we see the distribution of the burden of the disease. 110,26 accumulated cases. This is the new colored scale. We try to address and to report this information in the best way possible. And now we're using a different Pantone than we were using before with different colors. So you can have better understanding of the burden of the disease throughout the federal entities. We are using 2 states, the landmark states, that always pertain to the main category. We can see these states here with the new colors of our ranking, and you can clearly identify how the different states are moving on. So you can all identify the information you have according to your federal entity. Next, these are confirmed cases in the past 2 weeks. These are the cases that account for an active epidemic. You must remember that this is a moving window. It moves on a daily basis. So I'm just showing the last 14 days. Hence, the colors of the states with burden reduction will move from dark orange to light orange and then subsequently to green. This is what you will see in this map. And you can see the same information in the next slide with the same order. And you see how certain states are moving up and the ranking is moving based upon the recent evolution of the epidemic in these states. This is also the map in this new slide, but this is the incidence rate of active cases in the past 14 days. The dark green entities account for those states with most recent activity as compared to the lighter colors. In the next slide, we can see the visual representation in different terms, and we compare this information to the same situation 2 weeks ago. As we've mentioned every week, if the green bar is still up, it means that activity was higher in the last 2 weeks as compared to the baseline. If the bars match in size, it means that there is stability throughout these past 2 weeks and the baseline. If the blue bar is higher, it means that transmission and therefore activity in the past 2 weeks went down as compared to the baseline 2 weeks ago. You will notice major differences when we establish the comparison. Here's the distribution of deaths according to date of death. We can see the distribution of the 1,134 suspected deaths. We're awaiting the lab tests to confirm the positivity or negativity of COVID. Since it started as a suspected disease, we need confirmation. In this slide, you will see the death rate, but in terms of federal entity. You must remember that these are total numbers, these are absolute numbers. We're not talking about the population base here. So perhaps certain entities with higher population density will have a different death toll. In the yellow bars, you will find those entities that are still awaiting lab tests. This is the epidemic curve. In cherry, you will see confirmed cases, the 110,026 confirmed cases, and in mustard, suspected cases still awaiting lab confirmation. You've seen this upward trend without any type of plateau whatsoever. Of course, this is the sum of all cases throughout the nation. We are not talking about a specific state here. Today, we added another slide. Here it is. You will see the 48,822 still suspected cases, but here they are broken down into federal entity. So we can track the different states with a confirmed case burden, as we saw in the first slides, but as well, we can also see those entities with a fair amount of suspected cases. Perhaps in the last week, the cases went up and transmission went up in this particular state. But just as I already mentioned, suspected cases are distributed throughout time for over 20 days. It may be due to the fact that certain entities have not yet reported the data or have not entered the information to the database. This is why we still have 48,822 suspected cases, because certain states have more confirmed cases than suspected cases. This means that perhaps the figures may double, or we may have a different amount of confirmed cases when the lab tests are drawn. This is how you analyze the behavior as per federal entity. This is the epidemic curve. These are all the cumulative cases. The percentage increase from the baseline still prevails, and the baseline is the week in which we have the most number of confirmed cases. And you must remember that these cases are distributed over time, over several days. Hospital availability, 44%, general capacity, 97%, which means that 10,084 beds of general IRAG are in use, and 12,000 beds are available. This is the percentage distribution depending on the state. Mexico City went up to 80% of hospital capacity. Of course, with the reconversion, this may shift, but we must always maintain a certain balance and available beds so we can continue to provide healthcare services. We have Chiapas with 58, Baja California 55. All these entities have less availability, and these are critical beds. The percentage is similar to the formerly mentioned, and you can see that according to the different states, there is somewhat of a balance between the hospital beds still available and those that we need to retrofit in certain hospitals. There are beds with a ventilator, and they can provide healthcare services to a critical patient, and perhaps they may not be located in an intensive care unit, but most of them have been retrofitted, located in areas that didn't used to be an intensive care unit, but they have been refurbished and now they have rebuilt for these purposes. These are the notifying or reporting units. We have 793 reporting units. The amount of COVID reporting units has now increased by 1 based upon the growing need throughout the different states. As we mentioned before, ever since major adjustments have taken place with both mortality and lethality rates, the deaths that were uploaded to the platform are here. This is the time distribution, and we must always remember we've been fairly explicit about this. We're not saying that 625 people died in the past 24 hours. We're just saying that 625 deaths were reported into the system in the past 24 hours. And in blue, you will see the distribution or the number of days in which the deaths took place. So this is the actual occurrence. Here we see the same information but broken down into institution. The institution that entered the 726 deaths onto the database. 165 were reported by the Ministry of Health, 52 by other institutions, and the Social Security Institute accounts for 408 reports. These are the slides we update on a weekly basis, every Friday. This is the upward trend of sample processing. 296,924 tests have been drawn throughout the national network, including state-owned laboratories, epidemiological surveillance supporting laboratories, regional labs operated by the Social Security Institute for sample processing. 230,000 tests are still available and have not been used yet throughout the network. In this new slide, you can see the percentage of positive tests. The most complete week, the week with most positive results, is week 21. In week 21, you can see that the positive tested percentage is 41%. Last week, we reported 40%. It even went up to 42, and we report 46% today. As you will notice in the slide, regardless the increase of number of available tests, you can see that the tests drawn in week 18 were 12,000, 15,000 in week 18, 18,500 by week 20, and over 21,000 by week 22. But if you compare week 18 with week 21, so it means that a higher number of tests were performed, by 75 more tests were performed, but the percentage of positive lab tests only went up by 6%. So it means that patients that are actually test positive with SARS-CoV-2, they get the test done, but when the test is confirmed, when the sample is collected, we actually get the information and report it here. There's no direct relationship between how many tests I run. It doesn't mean that the more tests I run, the more cases I'll encounter. We can see it here in the positivity percentage. It remains stable regardless the number of available tests. Let's take a look at the last slide. The test distribution throughout the national public healthcare system. These are the new tests. These are all Chinese tests. It was an inside consolidated purchase, and 208,224 tests were distributed throughout the network. They were sent to the different states. Why are we reporting different numbers here? Because we're running a positivity analysis, the total population in the state, the number of samples processed throughout the week, as well as productivity. And through this analysis, we were able to define the number of tests that we sent over to the states. But this doesn't mean that we sent them and we're not going to send them again. No, INDRA has a reserve of 91,776 that are a part of the strategic reserve. And INDRE will continue to distribute the tests throughout the country, supporting laboratories are here, and there was a delivery to the Mexican Social Security Institute. We sent 50,000 tests to La Raza lab, which is a concentrating lab throughout the states. 208,000 tests were distributed. However, the tests around in the states and the tests that are part of the strategic reserve account for 230 tests that can still be performed. Thank you very much. Thank you, Dr. Alomia. Dr. Ricardo Cortés, will you make your presentation about the epidemiological stoplight, please? Thank you very much, Dr. Lopez Gatell. Good afternoon, good evening. Today we're going to talk about the COVID epidemiological risk stoplight made up by 4 national indicators, 2 proportion indicators, and 2 trend indicators. In terms of proportion, you have to base your understanding on the IRAG network. These are all the hospitals, part of the network and part of the system that report the number of beds available, the number of hospital beds already occupied. The second indicator is the positive percentage. So this is the percentage of tests that we have run throughout the national systems laboratories. All the patients tested positive. There are 2 additional trend indicators. So before I speak about them, I would like to say that the first 2 indicators relate to what is done throughout the states, because the Epidemiological National Reference Center, the folks at the IT departments, the laboratory staff, they all work hard to report this information. And the team, we must also thank the team coordinated by Dr. Alvarez Buya at CONACYT. These indicators are created by universities and colleges that work hard to create the data. The trend of hospitalized cases and the trend of the COVID syndrome. This is the increase or decrease of suspected cases. You will see the confirmed cases reported as positive cases, but in dealing with suspected cases, we have to be extremely thoughtful if these cases are ambulatory cases, or if most patients just stay at home, or if they are hospitalized. The country was broken down into 2 slides here, and you will see all these colors representing different indicators. The undersecretary made a decision, the decision of maximum caution or top caution, which means that Aguascalientes, although having green and orange indicators, they still have 2 red indicators. So there's top caution because we're only taking the red indicator into account. So if one of the 4 indicators is red, the whole stoplight will remain in red, and only those activities specified in the red stoplight or the red traffic light will be carried out throughout that state. The state of Mexico. So you can clearly understand how congruent these indicators are. Mexico, the state of Mexico, one of the indicators is orange, but since hospital capacity is about to move up to 70%, it will move to red. It has a high percentage of positive tested cases, so it's in red, and the trend of hospitalized cases is also red. So this data is provided directly by the Mexico state staff. So we see an upward trend all the way until we get the red traffic light. The whole country is in red. These are the next 16 states, the second half of the country. I believe the most unique case is in Zacatecas. Zacatecas has all the indicators, all the colors. So they have low hospital occupation, so they're still available to cover new cases. Their positive cases is yellow, hospitalized cases is still in red. They do have enough beds, but the trend of hospitalized cases is going up. That's why it's red. And the trend of COVID syndrome is also going up, but with a lower or a milder slope. Since one of the indicators is red, the whole state remains red. This is the national map. It's fully red, but it has a singularity. It describes the trend in hospitalizations. This is the state of Quintana Roo, for instance. Since one of its indicators is still red, the whole state is red, but in terms of hospitalization and the reduced rates, they're about to transit from red to yellow. They won't have any yellow indicators the next week, potentially. I'd forgotten about this slide. These are specific activities of the activities you can perform according to the epidemiological risk level. Hotels, for instance. And the red stoplight, 25 hotel capacity is allowed, as long as the guests prove they work in an essential activity and they're there in that hotel, the hotel due to business-related activities, and those business-related activities should be essential activities. Restaurants and cafeterias, delivery, takeout, and room service are the only restaurant and cafeteria activities allowed. Hair parlors, beauty shops, can we go to get a haircut? We can call them up so they can come home with the mouthpiece, with the most dignified, healthy measures, and that's why I'm here today with a haircut, ladies and gentlemen. Can we go out to the street? We can go out to take a walk around the block, always with safe distancing. So if somebody's coming the other way, you may prefer to cross the street and avoid making direct contact. So yes, we can go out for a walk, but we must never forget that we should stay at home. But we must always use our masks. But yes, we can work out a little bit. Grocery stores, same thing, one person per family and only 50% capacity. Spas, gyms, pools, they're closed. But as we move to the orange traffic light, they will be able to open their facilities by 50%. The gyms or the sports clubs will have to define the days on which certain families may still go to the gym or may perform their health-related activities. And of course, as the epidemiological risk goes down, more activities are allowed. So as we move towards the green traffic light, more activities will be performed. Schools will reopen always under the sanitation, hygiene, and health-related measures, the new etiquette, the new normal. These are more examples. Movies, theaters, museums, and cultural events up to 500 people, they are not allowed right now. So as the different states move on to a lower risk, or when they move on to the orange light, more activities will be allowed by 25%. For instance, movies. We no longer buy physical tickets, just by using a mobile device, you'll be able to purchase your ticket, therefore reducing physical contact. By booking your tickets, there's the possibility to reduce how many tickets are sold by 25%, by 50% when we reach the yellow light. Malls, they're still closed. Churches, they're still closed. And let's talk about massive events, concerts, amusement parks. They will remain closed in the red and orange traffic lights, and they will open up by 50% with the yellow light. Nightlife will open up when we reach the intermediate risk. Stadiums will also reach that very same level, but at the high level risk, certain events are allowed by closed doors only. This is why professional sports are currently being played in Mexico, but under this modality. So specific protocols have been designed as to safeguard the lives and health of the athletes, the coaches, and all the people involved in professional sports activities. Thank you very much. Thank you, Dr. Ricardo Cortez. We will start with the Q&A, and I would like to emphasize two elements. As Dr. Cortez mentioned, the overall stoplight where we describe the activities we will reopen as a deeper level of detail. We designed the protocol with the different authorities. I met this afternoon with the different health secretaries over a video conference. I had the privilege of meeting with two governors as well. These are all examples, okay? These are just examples of the types of activities. Throughout the different states, the sanitary authorities must identify their own social and economic activities within their entity. And of course, they may share activities and commonalities with other states, but always following the general criteria as to start to identify the activities still pending as to fulfill two purposes. Number one, you must understand that this information we just provided will not necessarily be exactly the same in your federal entity. Perhaps there are nuances, there will be certain variables established by the state authorities. And you must not be concerned about contradictions between the federal stoplight being because certain differences may arise at the state level because it's part of the joint efforts throughout the different states. And I also wanted to remind you something else. You must not wait. If you have diabetes, if you have obesity, hypertension, if you're a smoker, if you have cancer, or if you take immunosuppressives, if you have a health condition related to immunosuppression and you get or you find yourself with COVID symptoms, if you're older than 60 and you feel symptoms of COVID. And we've expanded the education just by saying you have family members with hypertension, you have family members with diabetes, and you're over 40, please don't wait. If you get fever, cough, if you have a sore throat, call us up, go to the hospital, because people are reaching hospitals way too late. And when they get there too late, not much can be done to save people's lives. This disease, in the onset, it may seem a lesser disease and the symptoms may resemble a common cold. However, if you have high risk of complications, if you have a chronic disease, or if you're older, it may catch you off guard. I share this information not only because anybody can show symptoms, but your family can show symptoms, your friends can show symptoms. So please help us out. Help encourage people going to the hospital, don't be afraid. Don't be afraid because you heard of somebody who got to the hospital with COVID symptoms and just died. It is very likely those tragic and unfortunate situations perhaps have to do with the fact that that person just got to the hospital way too late. This is a request from the physicians and from the healthcare professionals treating critical patients. So I wanted to come here and convey that message. Araceli Arandaide from Channel 11, Olinka, had questions yesterday. Thank you.
Thank you so much, Doctor. First of all, I'd like to ask you if the stoplight you just introduced has to be checklisted by the federal ministry once it has been presented by the states. And is there a standard date for each state to present it? Also about the test, I apologize that I insist on this, but you had 4 other serological tests, so in total it's 7. And you mentioned in May that in the US, the health clinics and medical control said that more than 50% were mistaken. So is this something from the new normal? I'd like to know your opinion. And also, how is Mexico looking with the whole situation with these tests? Thank you. Of course, thank you, Araceli. Regarding the epidemiological stoplight, this is the official one. It does not have to go through an approval exercise. It is approved by the Ministry of Health, which is the highest federal authority, with the Health Council as well. They take their advice, and the president, who has the ability to sanction some immediate provisions as well, which are not these ones. So do not look anywhere else. The deputy minister of the provision of health, under his authority by Article 10, recommends to the Minister of Health this epidemiological stoplight. It is then approved by the minister, and that's how it goes. We have also been discussing it with state health authorities, which are the heads of the executive powers at the state level. So we're talking about governors and state officials, and we have been getting into a consensus in a collaborative way. We didn't manage to do it this week because we had to modify our methodology, but on Tuesdays, we will send this updated information to the governors, and they have until Thursday from that week to discuss it with their technical teams. We also have brainstorming sessions like the one we had today at noon, and those meetings are to troubleshoot or address any solution. And when we do have some, we make it publicly on Fridays, like today. So the epidemiological stoplight is quite simple for now. Everything is red. It starts next Monday on June 8th, and it will be current until Sunday the 14th. So next Friday on the 12th of June, we will present the next stoplight in a weekly basis. Regarding the tests, let me go back to the general test map. For COVID purposes, there are 2 types of tests. We have A branch, which is the acute phase test. The interpretation of such tests, when it's positive, this means a person has symptoms that are COVID-like and it's positive, he will be confirmed to have COVID at that moment. And so within that set of tests, what they do is they identify the virus and the genetic material of the virus, the ribonucleic acid. And there are several variables. Some tests might take 6 hours, which is conventional and manual extraction. And then we also have closed tests because it comes up with a kit that does all the operations that they need to get it. And so the time can be faster. You can have the result in 1 hour. So let's not get confused by saying that one is faster. These are different. These are molecular tests. On the other hand, we have serological testing. They're called serological because they use the specimen of serum, and it's a component of human blood. And what we want to look for in this test are antibodies, not the virus, not molecules, but the antibodies. These antibodies are proteins that are developed by the organisms, so by human beings and other species who generate antibodies, but we're talking about human beings. And so we can measure the concentration of the serum in the serum of these antibodies, and we can do so with different technologies. The general interpretation of a positive result with these tests, so let's say a person has a positive result, this means that in the past, at least 10 days before, or perhaps it can go back to a month, 3 months, even 6 months, this person had an infection from the virus SARS-CoV-2. And that's the interpretation. So we have this branch with serological testing, and it has two variables. The first tests that are done in a lab and require certain technology with the specialized staff, and quick tests. We have the test strips, so it's faster, and you have a plastic device, and inside of it, it has a textile strip that has the needed components to have this chemical reaction that will identify the antibodies in human blood. For this test, the specimen is just one drop of blood. So they will just pinch your finger, they will put the droplet of blood on the strip, and you'll get the reaction. And at the end, you'll see a strip. In the end, the molecular tests are the gold standard. These are the tests we need to identify if someone has SARS-CoV-2 infection. The serological tests have a question mark because there is still a lot of debate. The jury's still out everywhere because the scientific knowledge regarding the speed that antibodies in the blood increase, you'll see that the time from when you get the infection and when we have an increased level of antibodies, so much that we detect it, the duration of the antibodies in the blood, and most importantly, if there are certain antibodies concentration in the blood, if that means that if it's a biological protection, but they are still in a huge question mark. There's no real science about this yet. So although we do have the technology, we do have the tests, everything comes down to the result interpretation, and it still has a big question mark. Now, out of these two, and out of all the tests that are done in the lab, the serological, not the molecular ones, serological tests are used with some technologies that are quite useful in the sense that they can identify the probability of a person who truly has the virus, or at least the record of the virus, and the probability of a person who has a negative result who truly was not exposed to the virus. And so it's possible that quite soon these tests will be approved by COFEPRIS and will be recommended for their use in the new normal. It's not true that they are indispensable. No one in the world who has technical and scientific knowledge has said that these are essential for the new normal. There's a huge expectation that everyone, the general population, the government, the companies, we would all like to have a diagnosis tool that during the new normal could help us identify if we had the virus or not. I think we would all feel safer and calmer to know, okay, I got it. I didn't even notice it, but now I'm protected. That's natural, but there is no science with that. In our lingo, this has been called a immunological passport or health passport because it functions like a metaphor. It means that you're protected. I can be outside. I can be out in the public. Nothing will happen to me. Just like if I were to have the vaccine. But no, that is not true. There is no solid and proven scientific evidence that this is true, although it's very legitimate to think that way. Now, on other occasions, we have thought, and it's often to see these information waves. So there's a lot of quoting and name dropping. Someone who says that someone else said that maybe yes, and we take it as a scientific truth, but that's not the way to go. That's not the right path. So I wish we had this tool, but as of today, June 5, 2020, we do not have it. Now, to wrap up on these quick tests, as we said, these are not characterized by their speed. That's not why they are called fast tests. It's just the conventional name we have given to these strips, test strips that can identify antibodies. And there are a lot of brands that want to enter into the country to commercialize these test strips, but they have a very low performance. The probability of having a positive result when someone truly has the virus or has had the virus is very low. This is a very sensitive feature, and I'm talking about 30 to 50, maximum 60%. And that's why the US health controls say that it's like tossing a coin. If you toss a coin and it has the correct balance, 50% you'll get heads and 50% you'll get tails. And that's why these are not the best way to go. And also, the probability of having a negative result when the person was not exposed to the infection, called specificity, is in the same percentage, 30 to 50%. So, the outcome of these tests have a high probability to have a false negative or a false positive and will not give the correct calmness that the person needs. Because you can have a fake positive just because the chemical reaction in this test strip was crossed over with other coronavirus that are within the population and to which we have been exposed, most of us. So to conclude, although COFEPRIS has approved 7 fast testing, this does not mean in any way that they should be used. Moreover, health authorities of the country have not recommended the use of these tests. Now, quite shortly, we will publish a brief recommending all state authorities not to use them because when you get a false negative or a false positive can cause some confusion and can even damage the person. So that's the current situation on that. Thank you very much, Araceli. Daniela Pastrana from Pie de Página, you have the floor. Thank you so much. Good evening, doctor. The other day, you presented some graphs with the trends with the states, and there was some confusion regarding the graphs that went higher in hospital availability, and they were much more higher than our forecasts. And that day you explained that it might have been because of a good work from the health staff because the more time they're hospitalized, the greater the chances of recovery. However, I'd like you to clarify a bit more the diagnosis that you have with these red spots that got everyone confused. Another thing that has brought up confusion are the dates. Many people in the imaginary collective, we thought that the highest point was going to be June 8th, but the numbers are not coming down. On the contrary, we have an upward trend, although you clarified today that it was regarding the Mexico City area. So even though we're not seeing any reduction, it's still confusing for the people. Why are the numbers still going up a month afterwards? So can you please clarify a bit more on this? Thank you so much, Patricia. Your question is very useful because they make us focus on the reality we're all living and the expectations we have for the next weeks. First of all, regarding the prediction curves that we will present next Monday, we present them once a week. We identified several types of curves. We have new and existing cases. We have general hospitalization cases that do not represent new cases, just people that at that moment, that day, were hospitalized. And the same for the intensive therapy unit. And we do these curves per state, and it's quite representative. Sometimes with the state of Guerrero, you might have 3, or Mexico City only has 1, plus the metropolitan area of Mexico City. So these 3 curves, from hospitalization with ITU and general beds, the numbers have been rising, and they also not represent new cases, just the sum of people entering the hospital that day, plus the ones who were already there. You will see that the number of hospitalization actually shows some success rate thanks to the clinical personnel in the hospitals, because they have managed to keep the patients alive. So that's what they need to do, and then they will get discharged and they will start their recovery. So yes, the period is getting extended, and that's why we see the numbers increasing regarding hospital availability. However, for curve number 1, this means new cases in the community. When the forecast goes beyond, and this is our technical interpretation about it, we can see that there has been more mobilization, more movement around the public space. First of all, we know that because we monitor the mobilization, and second, because the mechanism of the infection has to do with contact between people. So the state of Tabasco, with his government, just stated that they will implement the measure of cars not driving 1 day a week, just like in Mexico City. So I congratulate the governor of Tabasco, because as we have mentioned over the last weeks, their cases had been coming down, but they had a regrowth, like we have been talking about. And it happens. If the trend starts going down, that's great. But then if it comes up, if there's a upsurge, we need to be careful. And you'll see that Tabasco has an even higher curve than during the first wave. And that's how we interpret the curve. And Daniela, thank you so much for mentioning the date. As you well say, and as you have said in the morning press conferences, we have mentioned that May 8th was going to be the peak of the curve, the Senate, the peak. And we refer to the curve of the Mexican Valley. So the curve is specific to each location. So for the Mexican Valley, that was our forecast, and that happened. In fact, on May 7th, that's when the curve reached its highest peak. I'm talking about new existing cases, yes. And then we have the hospitalization curves that have that can be outdated by 10 or 12 days. And the reason is, let's say that a person has symptoms today, and then that person will have complications that will take them to the hospital. It takes about 5 to 7 days for that to happen. So when you have the ITU curve and we reach its peak, you'll see that it will be outdated by 15 to 20 days because it depends on the hospitalization of the ITU. But the information on May the 8th and what we presented was only for the Mexican Valley. Now, I understand that people are worried, and I feel that some people might be upset because they still cases upon cases, and the numbers don't go down. But as we said a long time ago, there's a huge difference between what you want, what I want. I don't want this disease to go on. That's what we all want. But the second thing is what we know what will happen. And we have methods to know what will happen. We knew this since January. And the third element is what we can modify. And it's out of this reality for someone to think that they can stop the pandemic or avoid it. Whoever has this expectation, it's quite legitimate and understandable, but it's important for them to go through the information not only presented here, but all around the world. This pandemic has impacted the whole world. So it's impossible to think that one country will avoid it or will stop it. So what we're trying to do is decrease the cases per day. That's the flattening the curve method. We still have an active pandemic that is growing, and because it's heterogenic, it comes up by locations. But when we see a cluster of cities that are in the middle, and we predicted that it was going to be at the end of July, we can see that at that moment the curve will start to go down. And we have Monterrey and Guadalajara that will go down at the end, expected in October 2020. That's all for now. It's 8 hours, 8:04, and this is the end of this press conference. Thank you so much.